Welcome back to the Therapeutics Chronicles. I'm your host, Momen Wali, and today we are diving into a medication that has transformed the management of type 2 diabetes, heart failure, and even chronic kidney disease. It's part of the SGLT2 inhibitor class, and while initially developed for blood sugar control, we now know that its benefits extend far beyond glycemic management. This is one of those medications that started in one corner of medicine but found its way into multiple specialties, from endocrinology and cardiology to nephrology. But as promising as Empagliflozin is, it is not without its pitfalls, from euglycemic ketoacidosis to genital infections and even volume depletion. There are key considerations healthcare professionals must keep in mind. So let's break it all down: how Empagliflozin works, when to use it, and how to avoid common mistakes, and most importantly, how to catch mistakes before they catch you. Before we jump in, a quick reminder: if you are preparing for pharmacy board exams or just looking to sharpen your clinical knowledge, check out our Telegram and WhatsApp study groups linked in the description. And if you haven't already, subscribe to the podcast and share it with your colleagues. I would also love to connect with you on LinkedIn, where we can keep these clinical discussions going. Alright, let's get into it. Empagliflozin is a sodium glucose cotransporter 2 SGLT2 inhibitor, a class of drugs that reduces blood sugar by blocking glucose reabsorption in the proximal tubule of the kidney. By doing this, it increases urinary glucose excretion, which not only lowers blood glucose levels but also promotes osmotic diuresis, leading to reductions in blood pressure and body weight. However, its benefits go beyond glucose control. Empagliflozin has been shown to reduce cardiovascular mortality, prevent heart failure hospitalizations, and slow the progression of chronic kidney disease. That's why it's now recommended not just in diabetes, but also in heart failure with reduced ejection fraction, HFrEF, and chronic kidney disease, CKD, even in non-diabetic patients. The standard dose for diabetes starts at 10 mg once daily, which can be increased to 25 mg once daily for additional glycemic control. In heart failure and CKD, the dose remains 10 mg, as higher doses have not shown added benefits in these conditions. Empagliflozin does not require dose titration based on glucose control, making it a relatively straightforward medication to initiate. However, it should not be used in patients with an eGFR below 20, as its glucose-lowering effects diminish with worsening renal function, though cardiovascular and renal benefits may still persist. Now, let's talk adverse effects. Because empagliflozin increases glucose excretion in urine, genitourinary infections, especially genital mycotic infections and UTIs, are common. Patients should be advised about proper hygiene and to stay hydrated to reduce the risk. Volume depletion and hypotension can also occur due to osmotic diuresis, particularly in elderly patients or those on diuretics. One of the most serious concerns is euglycemic diabetic ketoacidosis, DKA, which can occur even in patients with normal blood glucose levels. This happens because SGLT2 inhibitors increase ketone production, making patients more prone to ketoacidosis, especially during periods of fasting, illness, or excessive alcohol consumption. Empagliflozin is primarily eliminated via the kidneys, so renal function should be monitored regularly. While it does not cause hypoglycemia on its own, the risk increases when used with insulin or sulfonylureas, requiring dose adjustments of these other agents when empagliflozin is added. Let's put this into practice with some real-world cases. A 62-year-old male with type 2 diabetes and hypertension is started on empagliflozin 10 mg daily. A week later, he reports dizziness and lightheadedness, especially when standing up. What's happening here? Likely volume depletion due to osmotic diuresis. The solution: assess fluid intake. Ensure he stays well hydrated and consider adjusting his antihypertensive medications, particularly diuretics. A 45-year-old female with type 2 diabetes and obesity is prescribed empagliflozin for glycemic control and weight loss benefits. 2 weeks later, she reports burning urination and increased vaginal itching. The likely cause: genital mycotic infection. The fix: topical antifungals, better hygiene practices, and staying hydrated. If infections are recurrent, discontinuation might be necessary. A 70-year-old male with heart failure with reduced ejection fraction is prescribed empagliflozin 10 mg daily but is not diabetic. He asked if this is a mistake since he does not have diabetes. The answer, no mistake at all. Empagliflozin is now a standard therapy for HFrEF, even in non-diabetics, due to its ability to reduce heart failure hospitalizations and improve survival. A 55-year-old male with diabetes presents to the ER with nausea, fatigue, and mild abdominal pain. His blood glucose is normal, but his anion gap is elevated and beta hydroxybutyrate is positive. This is a classic case of euglycemic diabetic ketoacidosis (DKA), often triggered by fasting or acute illness in patients on SGLT2 inhibitors. The solution: IV fluids, electrolyte replacement, and insulin therapy, with discontinuation of empagliflozin until recovery. Now, let's go over key counseling points that must always be addressed with patients taking empagliflozin. First, emphasize hydration since the drug causes fluid loss. Patients should drink plenty of water to prevent dehydration. Second, warn about genital infections. Hygiene and recognizing early symptoms can prevent complications. Third, discuss DKA symptoms. Patients should recognize nausea, vomiting, and fatigue and avoid prolonged fasting. Fourth, review sick day management. Patients should temporarily hold empagliflozin if they are vomiting, severely dehydrated, or undergoing surgery. Fifth, advice on orthostatic hypotension. Encourage slow position changes, especially in the elderly. Lastly, remind patients that empagliflozin is not a standalone treatment. Lifestyle modifications and other medications are often necessary for full disease management. Now, let's wrap things up with some quick fire Q&A. What is the usual starting dose of empagliflozin? 10 mg once daily, which can be increased to 25 mg for diabetes. When should empagliflozin be avoided? It should not be initiated in patients with an eGFR below 20. What is a unique adverse effect of SGLT2 inhibitors? Euglycemic diabetic ketoacidosis. How can you minimize the risk of genital infections? Encourage good hygiene and adequate hydration. Why is empagliflozin used in heart failure and CKD even in non-diabetics? Because it reduces hospitalizations, slows disease progression, and improves survival. That's it for today's deep dive into empagliflozin. If you found this episode helpful, subscribe and share it with your colleagues. If you are preparing for pharmacy board exams, join our Telegram and WhatsApp study groups. Links are in the description. Let's continue the conversation in our WhatsApp group for the Therapeutics Chronicles podcast community. And do not forget to connect with me on LinkedIn. I would love to engage in more professional discussions and expand our network. If you have any questions, thoughts, or future topics you would like me to cover, feel free to reach out. Catch mistakes before they catch you. Until next time, stay curious, keep learning, and always question everything. See you in the next episode.